Hi everyone, and welcome to episode 31 of The Only Way is Ethics. We've had a hiatus for a little while to do our holidays, and we've been really busy in the regulatory compliance sector, but we're back. And I'd like to introduce our guest for today, Tom Chambers. Tom, thank you ever so much for joining us on this episode. Lots of people in the audience will know the format of the podcast. So what I'll do, Tom, I'll hand over to yourself. Give us a bit about your background, your clinical background, how you got into digital health, and what you're doing at the moment with Theta Sleep.
Yeah, absolutely. Thank you very much for having me on the podcast. I'm really looking forward to getting into some meaty sleep health and digital sleep topics. I'm an anaesthetist by clinical background, so an anaesthetic reg in northwest London, but have been in sleep medicine for the past sort of 4 or 5 years or so. Sort of fell into it reasonably serendipitously in an old foundation job that I had in a respiratory sleep team, all sleep apnea stuff, and just absolutely loved it. Like, loved everything about sleep medicine, loved the team, wanted to do more, went back for a fellow year and did a kind of particular sort of perioperative sleep apnea work. Like, sleep apnea is a big risk around the time of surgery, so how you identify, screen, diagnose it is a big problem. So got really into that, and eventually it becomes a problem of scale with sleep disorders and sleep apnea in particular. You know, there's more than 10 million people in the UK with sleep apnea.
Wow.
85% don't know about it. If you start looking, you need to work out exactly how you're going to manage it. And that was sort of the intro in it, and then just loved everything about sleep medicine, wanted to go away and do more, wanted to go and learn more and develop new interesting ideas. So have recently just finished a master's in sleep medicine.
Right.
And also recently just qualified or certified as a somnologist, which is a rather grand sounding title from the European Sleep Research Society, and came together at the back end of last year with 4 other people, in fact, to found our company Theta Sleep. And what we do is provide a tech-enabled clinical sleep service, and the whole purpose of it and the whole vision of that pathway is: how do you take sleep medicine care, particularly sleep apnea care, take it out of hospitals, deliver it in patients' homes, do it with all of the kind of digital enhancements that we can do it tech first, and be able to deliver kind of scalable, accessible, better, faster, cheaper sleep medicine care that's, you know, fully delivered in patients' homes. It's been a fun year. It's been a very interesting year. Lots of different challenges from full-time clinical work and anaesthetics, but exciting times ahead, particularly with, you know, the government's health plan and the visions of the community delivered digital first preventative healthcare. Is a very exciting time to be working in sleep medicine, and particularly kind of digital approaches to sleep medicine.
No, that's absolutely fantastic. And, you know, your journey into, and it's really interesting, isn't it? I think because as clinicians, we are now in that world of digital. It's front and center, isn't it? Whereas, you know, showing my age now, sort of, you know, when I started sort of like as a nurse, everything was on paper in relation to that. But now, if you're starting out in that profession, we're exposed to digital technologies. You mentioned as well about the the NHS plan. We talk about the NHS 10-year plan, and I think it's really interesting because, you know, front and centre for you guys is bringing these services into the patient's home. So we have one of the initiatives, don't we, from acute care into community, from hospital into community, and also so a lot of it around sort of like preventative medicine, and being able to sort of facilitate that. So where do you feel that Theta Sleep sort of fits in with that 10-year plan, and, you know, the links between sort of like, you know, sleep, cardiovascular health that lots of people won't realise, mental health, obesity, chronic disorders, etc. It plays a huge role. And I know my little bit of research into preparing for today, and I was looking through and I was like, blimey, I didn't even realise. You know, Fill us in a bit more in relation to that.
Yeah, I mean, it is one of those things that, you name it in terms of chronic long-term health conditions, and sleep disorders, and particularly sleep apnea is related to it. There is good evidence to show that people with untreated sleep apnea, and obviously being undiagnosed, you are by definition untreated, but untreated sleep apnea increases your risk of everything: cardiovascular disease, diabetes, dementia, obesity, ultimately an early death, and then other things: anxiety, depression, road traffic accidents, reduced quality of life. And not only that, but there is also good evidence that shows that if you do something about it, and if you try and screen and diagnose and treat people, you can make a real difference in terms of productivity, in terms of reducing healthcare expenditure. There's some great data from the States from a few years ago where it was a big trucking company who implemented a screening, diagnostic, treatment program for all their truck drivers. And they found that it's obviously based on US data rather than UK data, but just by implementing the screening, diagnostic and treatment pathway, they were reducing healthcare utilization costs by over $400 per driver per month. It was the data is there to show that if you make the change now, it solves so many problems down the line. It's a tricky one, especially in the NHS at the moment, where obviously there is not that much money going around for the preventative healthcare angle. And I do think that if we are going to get preventative healthcare right, sleep definitely needs to be part of that. I think 10, 15 years ago, it probably wasn't as accepted a pillar of health as diet, exercise, etc. But I think nowadays we are aware that it is diet, exercise, activity, sleep being a kind of key pillar of health and a key pillar of how to prevent long-term negative health outcomes. And that's both sleep health and well-being as well as clinical sleep disorders. And often the lines get a bit blurred and they can be a bit complicated between the two of them. But I don't think you can only target the sleep health element without thinking about the huge number of people with undiagnosed insomnia, sleep apnea, and other sleep disorders, which are obviously slightly rarer. But most people don't know about it yet if they have got a sleep disorder.
Yeah, and I think from my perspective as well, I've always associated the whole sort of like the study into sleep, etc., that as for me and my perception has always sat in that mental health space rather than the sort of like the physical health of the patient is the sort of like. And I think we had conversation before because my recent experiences of sleep deprivation and and being very conscious of that deprivation, going on a holiday, coming back, having that sort of, I'd never experienced an 11-hour sort of like lag in relation to that. And all of a sudden you get into this vicious circle and we see, I don't know if we're going to have to stop or I can continue, but the screen's just gone sort of like off.
Fingers crossed.
I think it's fingers crossed we're fine, and Luke can edit this bit out, but I will continue. So talking about sort of sleep deprivation and just being mindful of the effect that it has on you as an individual, and all of a sudden realising that it was affecting my physical health, my loss of appetite, my mental health started suffering. I started sort of questioning myself, not my sanity, but I was just really sort of like, waking up at 2:30 every morning, not being like, and seriously for the audience, not being able to get back off sleep. I know when you have conversations with friends and stuff like that, and they go, "Oh, I woke up at 2 and I didn't get sleep," but they drifted off at like 4 o'clock, etc. I totally did not get back to sleep, and then it became I'd gone past the level of almost needing sleep. I didn't know this was a thing, and I was functioning sort of. And then obviously being a clinician, I was like, I need to do something about this. And went down the sort of GP, chatting to them, got medicated in relation to a fantastic medication that really worked well. The melatonin route didn't in my circumstance. But do you feel that, rather than a sort of lifestyle nice to have in relation to awareness of this, that we should be concentrating this as a like a population health sort of issue?
Yeah, absolutely. And I think that point that you make about kind of realizing how you're feeling in the daytime when your sleep is disrupted, and you had such a kind of clear driver of what was going on there. You come back from holiday, your circadian rhythms all over the shop, and you're just completely broken in that stage, and you know what's causing that, but you still are having these daytime effects that you're very, very acutely aware of. And whereas there are so many people, if you take someone with sleep apnea who doesn't know about it, they've got all these sleep deprivation effects in the daytime, but they might have lived with it for 5, 10, 15, 20 years, and they just don't realise.
Absolutely.
And you've got all of those problems that without kind of screening for it, without educating people about the risks, etc., on that population health level, you can't do anything about it. And that is absolutely where it needs to start. And it is a really complicated question, because if you were to screen en masse the population and identify who is at risk of sleep disorders in general and sleep apnea specifically, you are going to find 15 million high risk individuals. And obviously then the question is what are we going to do about that? And how do you build the systems around to identify which of those 15 million people do you need to get on a pathway to try and get to treatment, and that you can have that kind of improved long-term health outcomes. I think identifying people is one question with screening, and then you obviously get to that next bit, which is, okay, how are we going to diagnose them, and then how are we going to treat them, and then how are we going to... But it absolutely does need to be a population health thing, because even when I speak to patients in clinic who we see for whatever sleep disorder, if they haven't been diagnosed with sleep apnea or insomnia or whatever, it might be that there are other elements of their sleep they just didn't realise about, or social jet lag, weekend problems, normal jet lag, if you will, when you're off on holiday, and that circadian rhythm disruption, or talking of clinicians, the effect that night shifts have on you,
were saying, that absolutely
is horrendous, and we are not good at, we don't know the best way to manage that. There's been some research into trying to use melatonin around night shifts with some reasonably positive effects, because melatonin is good as a circadian rhythm medication rather than a sleep medication. But that the research wasn't taken any further, and we expect our doctors, nurses, allied healthcare professionals to just sit through night shifts and change their circadian rhythms like they're going across the world, multiple times every month. And the kind of impact that has on work and on their clinical work is probably pretty well. There's some data on how bad it is, but I think we probably just have a scratching the surface of quite how bad it is.
Yeah, and I think so. You chatting about that whole sort of potentially the figures 15, you could potentially have 15 million people with sort of potential issues that need to be addressed. So is that in relation to treatment? Is that and I suppose I'd like you to bring in maybe around sort of how Theta can sort of help with this, because is there different levels of treatment, and so some more passive sort of things that you can do rather than sort of having to sort of get referred and do that real sort of full sort of interaction, because obviously people got busy lives and it all depends on social background, etc. And is there a cost involved in relation to this? Not everything's going to be free in relation to the the NHS potentially, and access also to treatment.
Yeah, absolutely. And I think that's why it is for all of these for any digital health innovation, you've got to be looking at that whole care pathway and how you can improve every step along that journey. And there is lots of stuff you can do with sleep in that kind of waiting well bracket. And I think across that whole point is screening the right people who are at risk of complications, identifying who is currently really suffering from the symptoms of their potential undiagnosed sleep apnea or other sleep disorder, not everyone with a sleep disorder or sleep apnea, if we focus on that, has got the symptoms of excessive tiredness and fatigue and all those other things. We're not always 100% sure why, but it's to do with the kind of quirks in the way we diagnose it, that we can't necessarily predict who's got a very heavy symptom burden from their condition, but you can if you ask patients the question, and you can do that en masse if you ask patients the question via digital onboarding. So like our kind of patient flow is we get the referral in from whatever source, GP or in the private sector, whatever it is, we onboard them onto our digital platform, and on there they get some education around sleep disorders, sleep apnea. We get a bit of a focused sleep history of those patients. So, what is the key problem for them? Ask some of these questionnaires around how severe someone's sleepiness, how much it's affecting them in the daytime, and also then work out what type of sleep study or sleep test that we're going to use to diagnose sleep apnea. Can we send this person? Because there's loads of new exciting innovations in the diagnostic space, but they're not perfect for everyone. You kind of have to select the right device, which can sometimes mean you have to have a clinic appointment, but you can collect a lot of that kind of before that clinic appointment if you do it through a digital platform. So you do that, and then you can identify what sleep study you're sending people, you get it out to them and get that scored and reported, and at each step along the way you can triage who are the highest risk individuals. Who's the highest risk because of their symptom burden before they're diagnosed? Who's the highest risk when you've got the diagnostic test done based on the severity of their sleep disorder or the severity of their comorbid health conditions or whatever it is? And they're the people who, if you do have a treatment bottleneck where you're going to struggle to get people on therapy, and the kind of first line therapy is always CPAP, continuous positive airways pressure, this little machine that sits by the bedside, bit of tubing, mask, and there's a massive education piece we need to do on CPAP masks. Everyone assumes they're these horrible kind of bane masks. I've had so many people describe them to me that way, and they absolutely aren't these days. The kit has developed,
moved on, hasn't it, a lot?
Massively. Nice lightweight nasal masks that are just a lot less obtrusive. It's still tricky to get used to, but they're not these kind of claustrophobic face masks. And there's all these other therapies, and that's where you get into that waiting well question about what can you do, that if there is a bottleneck to get CPAP treatment, what are the other bits of advice, the other therapies you can advise people on, be that improving their sleep health through improved sleep habits and understanding of sleep and circadian rhythm and impacts of caffeine and alcohol, all those things, or the impact of weight loss, diet, exercise on sleep disorders, or even simple things like some people with sleep apnea, it's fairly rare that it's a kind of, this is the key target, but some people, for example, have got sleep apnea that's only really bad if they're lying flat on their back, and actually if you lie them on their side with a device, or you can go pretty low tech about the whole thing. You used to sort of sew tennis balls in the back of night shirts. You get them on their side and their sleep apnea gets much better, and that if they're doing that for 6 months before you're able to move them on to the next piece, then there is lots of stuff you can do as long as you're kind of tracking that patient journey. And that, I think, is where having a platform that can monitor that whole patient journey and can keep a track of them even when they're then on treatment and how well they're using treatment is where you can kind of intervene and try and make a difference at every step.
Right, that's absolutely fantastic, Tom. And what I wanted to bring in there, because obviously we're talking about sort of like technologies, and you were talking about like the small masks, and I only know about those because my mum, and she's like, "Hi, mum." She won't mind me saying she's got post-polio syndrome.
Okay.
So she had polio when she's, and sort of, she's got some tilt in her spine, etc., and stuff like that. So there are respiratory sort of issues, and she was at the Lane Fox in St Thomas's centre, and had sort of like stayed overnight, had tests, and they said to her sort of like, you would benefit from CPAP. But unfortunately she's sort of like, of a certain age, and just has this claustrophobic sort of like, fears in relation to that. But I think, like you said, we're seeing technology move on. I mean, I remember my first sort of like interaction with sort of like CPAP many years ago, and it was like, oh my God, with the plastic sort of like round and the whole thing on
Yeah,
the face,
yeah.
and thinking, how could you possibly sleep like that?
Yeah.
But moving on from that, we now have as well, like you said, so many different technologies. We've got, you know, iWatches, we've got, you know, so many wearables, etc., and stuff like that. How have you found that from a Theta perspective? Is that a challenge in the sort of design and development in relation to that? Because we're at that stage now, aren't we? We're moving rapidly at speed, aren't we? And things are changing, sort of at a rapid pace. So how do you cope with that?
Yeah, it's one of the many things that makes being in the sleep medicine space really, really interesting. Like, and it's part of the thing that excites me about what we're doing and why it's so much fun, is because there are so many people innovating in the different parts of that care pathway, and it's kind of, right, how do we knit that all together, and how do we bring the right thing to the right person? So on the wearable front, I think that the key distinction for sleep tech, if you will, obviously lots of people are aware of sleep tech, increasingly wearables. Wearables, nearables, and airables are all separate technologies for sleep.
Okay.
So wearables, you know.
Please explain.
Wearables,
for our audience.
Smartwatches.
Yeah.
But not just smartwatch. You know, you've got in-ear stuff. You've got necklaces. You've got all sorts. In-ear stuff can be called an earable.
Okay.
And then you've got nearables, which are tech that sit kind of near you or close to you, and often in the sleep monitoring space and sleep apnea space, a lot of these are like under mattress sensors, and there's a few ones out there which collect great big data and are really interesting devices. And then airables are an even newer technology, which are all about signals that are transmitted wirelessly through the air, hence airable, and they can be, you know, put into smartphones, so you can use audio capture or ultrasound like technology in smartphones to track movement, and that can then, you know, be used to diagnose sleep apnea, for example. But the consumer sleep tech and the clinical sleep tech are very separate things. They're kind of, you know, CE marked, FDA approved diagnostics for sleep apnea, and the devices that are giving people sleep score in clinic. Now, obviously, positioning as a tech-enabled sleep clinic, you get lots of people talking about their consumer sleep tech, and it's really interesting, and it's about understanding how that consumer sleep tech helps or hinders that given person, particularly in the insomnia space more than the sleep apnea space. You get some people who get so kind of fixated on their sleep score that they actually go and develop insomnia, and that is called, in fact, orthosomnia. It's this phenomenon around wearable technology causing insomnia, because you try and get this perfect sleep score.
Absolutely.
Which is very interesting. But then the kind of more clinical side, the ones that are actually approved for the screening or diagnosis of sleep apnea, is a whole other super interesting area, because they can monitor sleep longitudinally, because we can do it every single night. Often we diagnose sleep apnea based on a single night sleep study.
Okay.
Either in laboratory or you know, increasingly, obviously that's everything we do is at home.
Yeah.
But one night can miss things. You know, our sleep is dynamic, our sleep is variable, and that is where wearables and nearables and airables and everything else can be very interesting, because they give a much more accurate, is probably the wrong word, reliable indicator of someone's sleep. And something like the Apple Watch, which last year released a sleep apnea detection software, like a validated medical device for the detection of sleep apnea, which is based on a multiple night assessment, is a really great tool, because that is probably, in a way, often, if that tells you you've got sleep apnea, the chances are that is more accurate for telling you do have sleep apnea than a single night clinical standard sleep study.
Okay.
The flip side is then the risk is that they don't pick up everyone. They're deliberately not really they're deliberately not super sensitive, but they're very, very specific. So if your Apple Watch tells you you've got sleep apnea, you almost certainly do, but it will miss 40% of people.
Right.
So that's the other danger in clinical use, is that, you know, I've had conversations with people who talk to me about their, you know, snoring and their sleepiness, and they say, oh, but my Apple Watch says I'm fine. And you're like, that is then a bit dangerous, because
absolutely.
And Apple will say, you know, it's not their positioning is, we're not a sleep apnea diagnostic.
No.
If you're worried, go speak to your GP. But it does make people falsely reassured.
Yeah.
So it's a kind of there is a very interesting kind of ethical conundrum wrapped up in all of that.
Yeah, no, absolutely, and I know that firsthand because I've got cardiac arrhythmias caused by vagal nerve damage associated to my colitis. So it's quite a sort of complex sort of like situation. But my cardiologist has said that the ECG on here is really accurate. He said it's one of the best on the market. You know, you've got some of those specific actual cardiomobile, etc. and stuff like that. And he said no, that's absolutely great.
Yeah.
But obviously when it works, and like you say, picking it up for like sort of a select group of patients, there may be some patients, isn't it, that it's not going to work for, and in relation to that. So we've got, Theta Sleep. You've touched a bit on sort of like, risk and safety, and we'll come on to that. Sort of, I have to, don't I, working in the regulatory space. But first I'd like to pick up on, let's come back to sort of like the 10-year plan, and in relation to sort of like, so obviously the big initiatives in relation to going from hospital to community, as we know, is the whole sort of like the initiative for getting people out quicker, or for them to be able to stay at home and not be admitted. So is there any space for Theta Sleep in relation to sort of like remote monitoring, virtual wards, long-term sort of like, use and management within NHS organisations?
Yeah, so with what we're doing, it's more the kind of those outpatient appointments and that outpatient care pathway more than the inpatient stuff. So there's the obvious link of, as we were saying at the beginning, if you identify, diagnose and treat your sleep apnea, you're probably massively reducing the risk of ending up in hospital 3, 5, 10 years down the line. So there's that. But then in terms of that, taking stuff out of the hospital and bringing it into the community, our whole thing is often people are still interfacing with the hospital to go and get their sleep study equipment, for example. So it's still very common that trusts and sleep services will own a certain number of sleep study kits, which are they're expensive bits of kit that the patients have to go in and out of hospital to pick them up, to take them home, to wear them, to bring them back, to hope that the data is captured properly, because if it hasn't, they're going to be repeating it. And you can imagine the number of trips that you end up having to do in and out of hospital, carbon footprint, worse patient experience, having to go in and out, busy lifestyle, working multiple jobs. How do you do it? So one of the big things there for us was just taking that, a bit more hospital delivered pathway and putting it completely at home. And the same is true for treatment setup. For like CPAP setup, the traditional model is you do it face to face and you get someone to come into the hospital. But actually, so much of it you can do entirely at home. You can get the education out to patients, you can get the device out to patients, you can have a video call or provide good accessible education content to allow it to all be done at home, rather than have to have any interfacing with the hospital. So it's that element of hospital community that we're focused on in what is a kind of predominantly outpatient specialty. But in terms of the kind of sleep tech generally and the virtual ward kind of angle, I don't know I don't have any kind of data in mind, but it would be very interesting to see with the longitudinal stuff of using those wearables that we've been talking about how they predict risk, because a lot of them have got oximeters built into them, for example. The watches, they struggle a bit because they don't work the same as hospital oximeter, if you will, with the infrared technology going through. They've got reflective, which is less accurate, and they can't do it beat to beat, but they can be used to find the high risk people. So that sleep tech and wearables, I think, is definitely a kind of angle for virtual wards and getting people out of hospital earlier and keeping a safe eye on them whilst they're out of hospital.
And I think the real positives from my perspective as well, or from anyone's perspective, is that with all these new technologies, and is the opportunities now in relation to how accessible this is. So there may have been groups previously depended on people's circumstance, that just couldn't have access to a lot of these studies and the provision of that. But now we're just making it so much more accessible in relation to that, which I think is absolutely fantastic. And we'll see that more and more, won't we? I think in the breadth and depth of different comorbidities that can be managed effectively in relation to that, with technologies. So you did touch on risk, and you did touch on sort of like, we've spoken about sort of, integration of third-party wearables and sort of systems, etc., and stuff like that. So obviously with any design and development, and lots of our audience will already know because they sort of like work in this space, is around sort of, this minefield that is regulatory compliance. As the audience may know or may not know at the moment, DCB 0129 and 160 are being revised. You have the medical device regulation. We will touch on AI during this conversation at some point as well. But it would be really good to get your perspective, Tom, in relation to, look, I'm someone that's worked in regulatory compliance for 18 years. But, you guys, you come along, you've got this fantastic idea, you want to mobilise it, and all of a sudden you do your background reading and your research, and you're met with, almost like some people describe it to me, I'm met with this brick wall.
Yeah.
And I've got to try and climb over it.
Yeah.
Or bust through it.
Yeah. And
how do I do that? So what were the challenges that you faced in relation to that?
Yeah, it's a good question. Actually, what we, from a very early stage, kind of focused on making sure we understood that landscape and did everything we need to do as soon as possible, so it wasn't going to be a blocker for that. We very much said, we want to build this pathway to improve access to care in the NHS, and that needs, hospital level compliance, and you need to understand that and get that done and focus on it. I think for us, because our tech platform is a patient-facing digital health platform and a clinician-facing sleep medicine specific electronic health record, it's not a medical device. So that was always, that was made the brick wall a lot smaller than it is for medical device manufacturers. Because I don't know a lot about that space, other than that the UK regs compared to the EU are a bit all over the place and tricky to navigate, and it takes a long time anyway. But it was a case of, for us, identifying, right, what are the compliance badges, sign-offs that we need for our platform, and identifying, that for us is CQC registration, so not digital health compliance, but CQC registration as a clinical service provider, and then everything that's in your DTAC. So obviously your DSPT, your DCB 0129, 0160, Cyber Essentials, GDPR, etc., and focused on that very early. And we, I knew the guys at Asuric, so Paul Jewell, who I was on a Byte Labs digital health fellowship thing a long way back, actually. And knew Paul through that, and very early on was kind of picking his brains on these things. I knew what he was doing, and then we started working with them, which made it, streamlined everything that we were doing and made life a lot easier. I actually personally really enjoyed doing the compliance stuff and the regulation. So I'm our clinical safety officer and data protection officer, and I've quite enjoyed learning about it and getting it done. The slightly sad realization I had is like some of the bits I've struggled with this year, being out of like clinical work and in the entrepreneurial health tech space, where you don't really know how to spend your time and what the most productive use of time is. Having a list of things that you need to go and like work out what you need to do and get them done, absolutely. I've oddly quite enjoyed. So have we spent first 6 months or so building that compliant platform and getting the CQC registration and doing all that was a kind of key focus. And I think once you've got the infrastructure in place and you understand what you need to be doing with your health data and how it needs to be secured and your obligations around GDPR, etc., it means when you're trying to add new features or develop new things or understand new systems, it just makes life a lot easier. It's definitely one of those things that you have to time box, that it's going to take you X number of months and that you need to understand it to be kind of doing all the right things, and obviously then doing the right things by patients. That is ultimately why all of these things are here, although it doesn't always feel that way depending on some of those hoops that you're trying to jump through. That is ultimately why it's there. And it's been oddly enjoyable at parts this year.
No, it's great, and it's really good. I think if sort of like people, and as we always try and give the message, it's best to embrace the standards and see them as a positive step in relation to your organisation, because I think, if you demonstrate compliance and that, as an organisation you're there to support that and the whole safety piece, then it just puts you in that sort of bracket above the rest, in sort of like, those people that really are sort of like standoffish in relation to that. So as a sort of like, you come from that sort of like startup, etc., and you need to get a rung on the ladder, and it's really difficult, I think, isn't it? Having we work with a lot of startups, etc. You are one of those, and you have to start somewhere, but there's a cost involved in relation to that. So how did you find it as a clinician, sort of like as well, sort of coming into this space, and all of a sudden it's like sort of we have these ideas we need to do, but there's lots of stuff that needs to happen: design, development. I need engineers. I need quality assurance. I need the regulatory space, and I think it's all time and effort of a team of people, and that costs money. So where did you start in relation to that?
Yeah, so I think for us it was kind of two things there. We did raise a bit of money. We did a kind of pre-seed SEIS backed fundraising round in February last year, and we are going to be raising another round again actually in the new year. But part of that, in terms of that mixture of skills, was because we were an unusually big founding team, that there's 5 of us. We've got senior medic, our medical director, consultant anaesthetist for 20 odd years, set up multiple sleep services. One of the other co-founders is commercial director in big blue chip organisations, so has done that kind of commercial strategy side of things. I was sort of sitting in the middle and trying to wear lots of different hats and learn as you go. And then we've got two of the co-founders are both tech guys by background. So one of them happens to be my brother, whose background is in education tech startup. So co-founded a ed tech startup a few years ago, kind of delivering millions of hours of tutoring globally. So kind of there's some interesting parallels between the kind of healthcare space and the education space, although obviously not from a healthcare background. And then our final co-founder and CTO, his background is in big Silicon Valley startups, kind of head of engineering at big, much bigger organizations. So the kind of technical challenges, he's a full stack engineer. He gets the design stuff from Will, who says, it's a really nice team, because he's got myself and David from the clinical side saying, this is what we want something to do. And then Will takes it from a product side, design, says this is what it needs to look like, and then within a very short space of time it seems to be built and ready to go, and so that stuff has been great in that we have a lot of the skills in-house, but then obviously had to raise money to be able to fund the build of the product and pay some salaries and keep paying a mortgage and other bits and pieces. So it was a combination of having the skills on the founding team and knowing where you had to go to experts like yourself in the compliance space to say, what do we need to do here and how can we approach this, what can be done in-house versus needing external support, and then I think having to raise the money to be able to do that, to get going quick enough to build something meaningful and try and get it in the hands of patients and being used.
And in that space and talking about that sort of like, raising funds, etc., did you find, it would be good firstly to sort of like, how did you find that experience and what support did you have from different sort of like, organisations, if that was available? And what would your advice be? You've spoken about your team, and, I don't think that's sort of like, for a lot of organisations, having someone that is Silicon Valley and has done all of that sort of stuff, that's not
doesn't happen often.
It doesn't happen often, and
we are spoiled.
That's not the norm when we're looking at that in relation to that. So what would your advice be to, like, if there are people sort of listening and they are starting out in this space, or a group of clinicians that are like, we've got this idea and we need a team of people, where should they go, or how should they approach that?
Yeah, I mean, we were certainly spoilt in being able to have that team that covered a lot of those bases. So I would be disingenuous, and I'd be lying to sit here and say I know how to go and find a great product person or a great software engineer, because we were fortunate that we had that coming into the team. I think on the fundraising side, certainly for us, the thing that I think made a big difference, the round was kind of all angel investment and was through this SEIS kind of fundraising scheme, the government backed kind of for startups fundraising scheme, which is incredibly attractive as an investor and definitely made our lives a lot easier when it came to that. So that's definitely one thing on the fundraising side. On the team, I think it is a case of working out what problem you're trying to solve and how you're going to do it. So for us, it was obviously the sleep apnea care pathway and sleep medicine in general. And it was, we need senior clinical input, we need the compliance side, we need the tech input, and we need the sales input, and then working out where your gaps are and what of those can be outsourced or used with like a consultancy of whatever form, or can you find the right kind of co-founders or early hires to do that with you. I think increasingly there are great digital health networks, particularly in London, of where you can find people, and the number of kind of WhatsApp groups or Slack channels or whatever that people are going out for jobs, or obviously LinkedIn is great nowadays to try and find those people. I think it is a case of working out what you need to build your vision, and then finding those people before you embark on that, because otherwise I think you could get quite stuck quite quickly. It'd be the same as the compliance side, wouldn't it? As if you get 6 months down the line and you've built something with, you've tried to shoestring it yourself or not done it with the right people, and then unraveling that, I think would be a pretty painful experience.
Yeah, no, absolutely, and I think you've hit the nail on the head there in relation to whether it's regulatory compliance, whether it's sort of building your team. I think we're in that space now where whether it's sort of we hear this word fractional, or sort of it's just another word for consultancy, isn't it, in relation to that. But it is about sort of best of breed and utilising people, that SMEs that do have that experience. Lots of time within the digital health space, we see people sort of like that struggle, or they feel like they know best. They try and keep it sort of in-house, as it were, and they don't necessarily do the best job. And dare I say it as well, there's some organisations out there and sort of like startups that where it's evident there is no clinical input into those technologies. And for me that's an absolute car crash, because you're going to run into issues because you don't know the sector. You don't know the clinical, non-clinical workflows. You don't know the management. You're just like sort of almost, aren't you, like sort of finger in the air type scenario. And as we know in our space, and as clinicians sort of like ourselves, that's just a recipe for disaster, isn't it, in relation to that? Yeah,
absolutely. I think obviously anything in a digital health space, I think you've got to have clinical input from the beginning, and it's not just sort of that saying that it has to have a clinician in there. It's that whole, as we were saying, understanding that whole pathway and understanding the whole vision of like, who are the stakeholders at every point who make a difference to what you're trying to do. Who are the patients going through it? Who are you interfacing in primary care and secondary care, tertiary care? Who are you going to be appealing to in terms of trusts, ICBs, etc. And then understanding who knows about that space. Obviously, as clinicians, you've got a good understanding of what happens in the hospital or in primary care or wherever your clinical area is. Then obviously outside that, there's a lot of there's a lot of blank spaces in, I've certainly learnt a huge amount in the past year about navigating various kind of NHS hierarchies, and that's again where you need that network to speak to people to understand who've been in it for longer, who can help you understand how things are all arranged. So it's like you need that person who can understand how the NHS functions. You need someone who understands the clinical. You need someone who understands the compliance. You need someone who can build. And it's about having all those skills and just being aware of what you don't have to and then work out obviously how you fill that gap.
Yeah, and that doesn't have to be. I think people sometimes look at it and it's like that doesn't have to be a full-time person within your organisation. It can be someone that's there in an advisory capacity, that making sure though that you're utilising them effectively within that organisation, and they are front and centre in relation to decision making. So wearables, Theta Sleep, we've got lots of data and information that's coming into the sort of like the platform, and then over the past however many years we've started to see the rise of artificial intelligence, and it's building up momentum very quickly in relation to the space, and we know the benefits that come with that. We'll start with the benefits that come with that. So where do you see AI and where it fits in relation to sort of like sleep studies, the apnea space, etc.? Because, from the conversations we've had already on this episode, I can see front and centre sort of like, wow, AI could be all over this, and how it could support clinicians and patients in relation to being able to assist, especially with sort of like big data sort of in relation to being able to support.
Yeah, absolutely. I think I'm certainly no expert on AI and understanding all of what it means. Often when we talk about AI, I'm not sure we often know exactly what we're talking about in terms of all the various different things. I occasionally have this conversation with Will and Ollie, and they will then talk about all of these various things that I've got no idea about. And I think AI has obviously come into the kind of modern lexicon with LLMs, with your chat GPTs, with your Claudes, with your whatever, and everyone kind of sees that as AI and that generative AI. And there's lots of use cases for that in everything. But I think kind of AI machine learning stuff has been used in technology for obviously before generative AI came along, and I think already in sleep tech and in sleep tech for the last few years it's been in place. Any auto scoring of sleep studies, so obviously sleep studies, many different ones. The traditional sleep study, respiratory polygraphy, is what we give patients, which has got prongs in the nose, bands around the chest, bands around the abdomen, probe on the finger, monitors your breathing, your heart rate, etc., etc. And a lot of those can be scored by an algorithm first, and then they have to be manually overscored by someone who is clinically trained to do that. But they are all AI algorithms that work very well. And then there's the thing that I think is really interesting from a sleep medicine perspective is the kind of AI tools to be used in a big data perspective. So when we're talking about the 9 million people with undiagnosed sleep apnea, how do you go out and screen them? If you took GP records, big health data, and looked at the comorbidities, you could probably build a model reasonably quickly to work out who can you screen and identify as the highest risk. I was having a chat this morning with someone who's doing a PhD in AI, big data, and sleep apnea, and we were chatting about how you can, whether there is a world in which you can actually take people straight from GP records and say you are the highest risk, and actually can we even, slightly blasphemous at the moment to say it, but can you skip doing a diagnostic and try and put them straight on therapy? Like, is that the way you do this at scale?
Wow.
There's some really interesting things there, and there's the wearable longitudinal stuff. There's some amazing insights. The under mattress sensors that we were talking about earlier. It's particularly one that a group has done lots and lots of publications on, of the Withings sleep analyzer, which sits under the mattress, longitudinal monitoring, and it is an FDA approved sleep apnea screener and diagnostic. It tells you the severity of sleep apnea night to night, and there's been some amazing insights about variability in night to night and whether that predicts certain risk. And there's been insights about the weekend effect of sleep apnea and stuff, and these are all kind of new, ostensibly AI driven insights, because they're big data and the underlying algorithms are AI. For me, in terms of what we're looking at kind of in the short or medium term with Theta Sleep, is how can you use some of this exciting generative AI kit to give a better patient experience. So non-clinical stuff, because of all of the AI as a medical device rules, regs, understanding, which again is not something I'm super clued up on at all. But how can you use the sort of generative AI chatbot style stuff to help with some of the more administrative tasks? So our platform generally relies on patient collected information that they input onto our progressive web app. So they do it by the phone or the computer or whatever, and they will free text in information. Obviously that's not accessible to everyone, and we have a telephone supported pathway where a support member of the support team can talk to the patient and get all that same information. But that you can do over a telephone, where you ring an AI kind of agent on the other end of the phone and get all that information. Similarly, on the kind of adherence side, that when people are struggling with CPAP adherence, for example, is ringing up and explaining the problems and taking that, but not being used as kind of clinical decision makers, or not being used as, partly because not the clinical safety side of things, let alone the regulation. It's just the how do we use this safely. I think there's obviously so many ways that it can be used, and part of me often, as I said, struggles to know what we're necessarily talking about in all of those each kind of instances.
And I think we're in the space at the moment, aren't we, where AI has been around for longer than people are aware of, the majority of people, but we're still learning. I'm still learning, even though we've put together an AI governance and risk management course recently, because we've seen the need, and the knowledge gap is huge in relation to that. But you mentioned sort of like big data and looking at that. Where do you feel we lie in relation to the danger of and being cognizant of? There's a big push to try and go from AI that's assisting us in certain processes and is using supervised learning to sort of like, so that we can pretty much trust in it to say, okay, we've put these inputs in, we've got these outputs, and we're assured that this is going to assist us, and that we've got a human in the loop, as opposed to sort of like we're forever being challenged, aren't we? And there is going to be a more need that I think the longer we use AI, there is going to be this push, isn't there, to say, oh, okay, well, impress me now. Do you know what I mean? You've been doing this for God knows how long. And unfortunately, some health organisations and some manufacturers are further down the line with that and are promoting these amazing sort of Ferraris of the AI space that can do all these wonderful things. And there are other organisations that are more risk averse and are like, no, we're just backing off and holding off in relation to that. But do you think we're in danger of sort of like moving too quickly? Because I think especially in the regulatory space, we haven't caught up. Europe are way ahead of us in relation to what the EU AI Act, and they've mandated it. We don't have any mandated regulation for AI in the UK at present, but we know it's coming, but we don't know what that looks like. What does that mean for an organisation like yourselves, and what do you do to prepare for sort of like what is coming?
Yeah, it's a really difficult question, isn't it? To know the
Sorry,
balance.
Put you on the spot in relation to that.
It's the balance between you have to. It's like obviously my whole professional career have been in and around computers. Saying at the beginning of showing your age, I always think that I potentially sound younger than I am if I've never written any notes on paper. It's every hospital I've ever been in has been an electronic health record.
Okay.
Which I think was partly where I did my foundation training. They were sort of reasonably forward facing, but I think you have to be using AI tools at the moment, like however many years ago you had to be using computer tools, and you had to kind of understand where they fit in your workflows and how best to use them, and just move in that safe way that you can try and understand it. I mean, anyone using LLMs for anything has probably been through that. You can ask it any question and it pumps out stuff that is largely nonsense and can't be trusted, but actually if you kind of give it a bit more context and you try and understand how you can fit it in workflows, it can improve what you're doing, make things better, make things more efficient, potentially allow you to deliver better care ultimately. Because I think that the other side of just thinking we don't know how to regulate it yet, or we don't have the regulatory framework in this country at the moment, and there's a sort of fundamental disconnect, a sort of unstoppable force and immovable object about all-purpose AI or unexplainable AI that can do more interesting stuff that we're never going to be able to regulate in our current framework. So they will just sort of fundamentally never gel together. But you can't not try and understand it and think about how they can be used, because then you're doing people a disservice in 5 years down the line. And I certainly don't have the answer on it, and I don't. As I said, at the moment, our kind of use cases are we work with providers of devices that use AI as fundamental parts of what they do. We're looking at how you can implement some of the more for the administrative tasks, not in the kind of ambient voice technology side of things. Obviously that is a separate kettle of fish and probably a whole podcast episode in itself.
Yeah, it is. It will be coming up at some point.
But trying to think about how can we use some of these tools and these flows to improve the pathway and improve the care, but it's not it's that trying to strike that balance of not going too fast, but you actually are probably being unsafe by not trying to embrace it in some way, because going all the way back to the beginning is ultimately if what we're doing to manage a problem at scale, you have to start approaching things differently. Like I was saying, that can you go from not even doing a diagnostic test and putting someone straight on treatment. You have to have these kind of, as long as they are within the right clinical protocols and frameworks and pathways and SOPs, etc., and all the other kind of compliance and governance you'd wrap around it. I think you've got to try and understand how they work and embed them into your flows a bit, haven't you?
Yeah, and I think we're at that point, aren't we, where artificial intelligence has accelerated rapidly, and I think one of the issues we have at the moment is that, like you alluded to, Tom, at the start of the AI conversation in this episode, is that what is AI?
Yeah.
And I've gone to lots of people at like conferences, walking around and sort of like on their stands, and had interesting conversations, and they say exactly the same things. It's like in general, do we understand what AI is? And you need to make sure that we're very clear about the concepts and sort of like, and the terminology we're using, like you say, with, LLMs and generative AI and machine learning, simple algorithms, complex algorithms, unsupervised learning, supervised learning, etc., and all this stuff.
Yeah.
It's a whole new world. And if you take all of that, and then if you look at, some of the studies that's been done around digital maturity within the sector, which we know is lacking, and that's just in relation to what we have at the moment and the technologies we're using. And then I don't know whether you're aware of a paper that was completed by Dr. Keith Grimes around the regulatory compliance sort of landscape in healthcare, and they just asked high-level questions to health organisations about, do they get 129 safety assurance evidence from the manufacturers, and are they producing 160s themselves? The stats that came out of that, for those people, there's lots of people out there that know the stats. 71% of digital health technologies have no safety assurance in relation to that, and that's us just talking about the technologies we have. So if you take those statistics, and then what health organisations are trying to do is bolt on AI on top of that, it puts us in a bit of a precarious position.
Yeah, and actually that point brings back see, as we're recording this in Hale House and was here last week maybe for a regulation in AI event.
Very topical. with the Assure It guys and sort of
and the one of the great questions from the audience was from a GP who was saying, should some basic understanding of digital clinical safety be part of everyone's statutory and mandatory training? Totally. And I think the answer is clearly yes, it should be.
We're all going to say yes.
But and it is true when you take fire safety, that everyone has to do, and yet there isn't the kind of basic understanding of what digital clinical safety is. And I think that is such an important point on the whole AI revolution. Is the reality is we really aren't there on an organisational level to be able to embrace these technologies because the fundamentals aren't there, and actually the sort of non-sexy work of how do you bring up those fundamentals is going to be absolutely key to that 10-year health plan of how do you actually implement this stuff. And I think that it was what is good in the 10-year health plan about the focus on actually how the fundamentals of getting interoperable data, etc., and the training that we were talking about that has to come with it. But yeah, it does sometimes feel like there are still plenty of trusts that are on paper for many things, and it does then seem madness about some of the conversations of a mass rollout and how you do that effectively and safely and well. And it's back to that point of how do you balance those two things? We need to be using these technologies, but they're not ready everywhere, and I do think that we probably do need to spend more time on those fundamentals, even right through from education of teaching at when you're training nurses, training doctors, training physios, training whomever of digital health and what it all means, and its own. So I know, again, talking of Keith about wanted a subspecialty of digital health, and that is a kind of thing in itself. There's lots of interesting things that can be done in those spaces, I think.
And it's really interesting talking about sort of unfortunately I couldn't attend the sort of regulation of AI that talk here at Hale House, and I think we're very good at talking about the fundamentals, and I did pick up on this, and I did feed back to Paul at sort of Assure It, etc. on that, saying I think we need to, and I did I'm going to put something out on LinkedIn in relation to that as well, is that, and I find this in digital clinical safety as well, is that we people know the principles, but it's about the application and implementing and the operationalizing sort of in relation to that, which I think we find difficult because no one's really talking about that. And I think that's also reflected in, so we did one of our episodes a couple of months ago, was the day after the 10-year plan came out. So we were all scurrying around. There was four of us on there. I don't know whether you saw Hassan Chowdhury, Clive Flashman, Shane Tickell and myself, that we did at the patient safety learning offices, around this is great in principle, and it was almost like it almost seemed like a campaign document.
Where's the delivery
plan? And it's where's the delivery plan in relation to that? And I think we're starting to see some roads of that coming, but also you're talking around sort of some of the training and this being sort of like core. Hot off the press, we had the CSO coffee and chat today, and Helen Balsden was on that call as well, and it's really refreshing to hear some updates in relation to the standards. Look, we know we're not going to see the revisions until next year. You know, for anyone that thought when we had the working groups at the start of the year that we're going to see something by the end of the year, that's
optimistic.
That's very optimistic in relation to that. But also some good news around sort of like the initiatives around training, because we do need to raise awareness that is going to sit under the Digital Skills Network now, which, you know, the NHS Digital Skills Network has responsibility for all core training. So hopefully we start to see that sort of like aligned, because there was talk around they're going to align that with, and Tracy Herlihy was on the call on the coffee and chat as well, in relation to taking some of those principles from patient safety and applying those to digital clinical safety, because we need to be working together. Because patient safety is always sat with clinical governance, and digital clinical safety is always sat under IT.
Yeah, and you can't really. The two are not separable, really.
They're not absolutely in relation to that. But let's not sort of like ponder on sort of like regulatory compliance, because that's not. We're not here just to sort of like, you know, talk about that. But looking at the sort of Theta Sleep platform and you know, how do you see that sort of supporting like a shift from sort of reactive care to proactive care in relation to that and its support?
Yeah, so the biggest thing for me there, and if we think of the patients we've got in our service and on our platform, is for that whole journey, so that they've got to have got into the system. So we're, you know, there's a whole proactive care piece at the beginning that we talk about with preventative healthcare and education and understanding of sleep medicine. So there's that. But in terms of kind of our patients and use of digital tools, the most exciting thing there is around trying to improve adherence to CPAP therapy that we were talking about before. So obviously, as we said, the tools have come on a long way. The CPAP devices are much better than they used to be, where they were, you know, single algorithms. You know, there's plenty of AI algorithms in CPAP machines for sure. And even going back when we were talking about older devices and stuff, the pre-CPAP days, this is a sort of random fact point, but pre-CPAP days, severe sleep apnea was actually treated with tracheostomies. There are, I don't know if there are hundreds, but there were certainly tens of people who had tracheostomies for sleep apnea before CPAP came along. CPAP only came along in the 90s from Australia, a guy called Colin Sullivan.
Every day's a school day, Tom. I didn't even realise that.
Yeah, that was a real digression to what I'm excited about. But it does link to the... No,
it does, totally.
So CPAP now, you know, again, compared to what we used to treat people with, is great, and there are the other therapies coming, but how you improve adherence is so important. And there was a great paper earlier this year that looked at patterns of CPAP adherence, because we know that patients struggle to use it absolutely as prescribed. 100% of nights using it for more than 4 hours a night is the cutoff that we go for. Is very difficult, and it's imperfect for any behaviour change, but the same is true for anything. The same is true for any medication. If you look at medication adherence, it's not great. But the two great things are, one, we know that you need to intervene really quickly for CPAP adherence. It's not enough to wait for 30 days and see how people are getting on and have a look, because all of the devices have got modems in them, so you can review the usage data on a nightly basis and pull that data. So it's not enough to wait for 30 days. You have to do it straight away. And digital adherence tools and digital nudging and digital monitoring can massively increase the adherence. So you go from sort of 50% adherence to more like 80-90% adherence in some studies. And being able to implement those simple digital tools, you know, bit of nudging for when you've seen that a patient's CPAP adherence has dropped, and you send a quick text message or email or whatever that is that can go off automatically to say, looks like you had a bit of a problem last night, can we help, can you get in touch? Or then there's an interesting angle of how can you almost gamify the adherence, how can you improve. That's where wearables might come in quite nicely, because you can look at how these scores might improve with using the therapy and not, and they're the areas for me that are really exciting from a proactive rather than reactive perspective, is that kind of continuous monitoring, intervening before there's a problem rather than waiting until after there's a problem. And again, a lot of the infrastructure's in place with the tech that we use in the clinical sleep world. It's just about knitting that together and then improving the patient experience through that.
And I think we've now got the technology to be able to improve sort of like rapidly in relation to that, and it gives us these opportunities, which is absolutely fantastic. Now, we can talk about our general workforce, but obviously, we're both clinicians, so I'm sort of like, in relation to the forgotten patient safety issue. We're working in an NHS at the moment that is under a lot of stress and a lot of pressure. Unfortunately, I've seen that sort of over this weekend firsthand, through exposure to accident and emergency and aside from that, but it opened my eyes to where we're at. I was walking corridors, and we've got sort of chatting to some people that I used to work with, and sort of 60 people in like 284 people in A&E, with 60 of those being in corridors, which means that our workforce, as I could see and observing as I walked around, looked very tired, very stressed, and dare I say it, if they had other options, probably wouldn't be working in that space. And you mentioned at the start of the episode around sort of like the capabilities for sort of like and the opportunity that's there for sleep studies and sort of etc. And the work that you're doing in relation to trying to sort of not just raising awareness, isn't it, in that, but what can we do in relation to supporting our clinicians and our workforce, and is this something that really we should be pushing forward? I know it's tough, but I think it means that I think it's of great importance, isn't it?
Yeah, absolutely. And I think it feeds into everything that we're saying about prevention, long-term health, etc., and focusing on the staff in your workforce. When I was on a recent ITU placement I was working on, I was asked to give a talk on sleep in the ITU on a patient-facing side. As you can imagine, ITU is about the worst place you could possibly be for sleep, with activity overnight and unusual lighting and noise and illness and pain and everything. But one of the key things I focused on the end was on that, what about the staff? What about focusing on those individuals? And it would be a bit trite probably to suggest that if you fix sleep and you prioritise sleep, you can fix all of those other problems, obviously. Yeah. But there is a huge amount of sleep health education, shift work education, circadian rhythm education that can be used and should be used for staff to improve their enjoyment of work, their productivity at work, their safety at work, all those things. There's a couple of great charities. There's one called the Footsteps Foundation, which has a kind of a sort of education program for shift workers around education around general sleep and education around shift work, and also using a few kind of questionnaires and stuff in there to screen for sleep disorders and screen for things like insomnia, sleep apnea, circadian rhythm disorders, and particularly around shift work. There's so much that can be done and so much more that should be done. I mean, I guess it's worth it's worth sort of reflecting, I think, sometimes of how much better it is here than, for example, still in the States, where they do the much more regular kind of 24-hour, 48-hour on calls, like used to be the case here, however many years ago. Yeah. And the data there is really frightening. It's old stuff, but there's a psychologist called Stephen Lockley who did a load of work on circadian rhythm disruption and sleep disruption in shift work in doctors in America. And showing that like the 48-hour on call versus a kind of even 16-hour shift being the 16-hour shift being the good thing. Yeah. The number of kind of serious medical errors, something like 35% per shift was the reduction by having a set shift pattern rather than the 48-hour on calls. Wow. And there's so much really interesting stuff I think that could be done around shift work, as I was saying, about the potential of melatonin for shift workers, the potential of targeting your shift patterns to the right people. So this idea in sleep medicine and sleep science around circadian rhythm and larks and owls, and like if you're an early bird or if you're a late night owl or early bird lark. And some people have looked at research if you take your late shift people who are probably quite happy to work a shift from 8 p.m. till 3 a.m. or something and stop there, and then then finish and get home. And similarly the other side, if you're a super early bird, maybe you can start work at 5 a.m. and do that shift, and how you can almost do a kind of circadian optimization to the shift work, which is the science certainly checks out. Again, I think you would just run into a brick wall of the reality of trying to implement that in a tired, overstretched, A&E department, for example. But the kind of the low-hanging fruit is there. The education piece around sleep disorders, how to try and optimize your sleep during and in between your night shifts, how to reduce your sleep deprivation before the nights, how to recover as fast as possible, use of basic things, sunglasses, eye masks, earplugs, etc., which should be a core part of kind of anyone working shift work, but it isn't kind of up and down the country, and that would be genuinely low-hanging fruit to improve some of those things.
Yeah, and I'm really miffed by like sort of the small amount of research that I did do, and just going through sort of like some of the topics that we are discussing, that we aren't more conscious within our health service, and not just the health service. And I know I'm sort of like in relation to this, what's the word I'm looking for? I'm a bit biased in relation to, because we're clinicians, but any workforce in relation to that, I did a lot of nights as a nurse. I loved them because I am a night owl. But you're absolutely right. You get to about 3-4 o'clock and boy, you start sort of, and then I'm having to do the sort of sometimes, and close your ears audience, that if we knew it was going to be a busy day shift, we'd pick up the morning drug round for the early staff to get it
to get it running,
done.
To get it off,
yeah. And you're at the end of that 12 hour of that sort of like
some of the data on.
Yeah, of that shift. When you're in lower lights, you're not putting all of the lights on, etc., and all that sort of stuff, and all of a sudden you're off you go with that trolley. Half the patients are still asleep. So there was the mentality of none of this check-in and stuff like that. Look, I know, guys, this was a long time ago. However, when you look at that, I'm just really surprised that this isn't front and centre in our occupational health departments within the hospitals, and that on induction and on, you already mentioned, and it'd be really good, Tom, at the end of this, that we, anything that you have mentioned in relation to that, we'll take those links and we'll pop them on these sort of on the podcast for people to go and look at, because I think it's absolute sort of like gold dust in relation to that. But it's really surprising that we're not doing more, and even offering digital solutions, whether that's I don't know, whether it's the Theta app or whether there's educational pieces, because we've got technology now in the palm of our hands and embedded everywhere, so that when we go home from a shift, or when that we do have prompts and suggestions in relation to, right, you've just come off a shift, you now need to, or you should sort of, don't do this, and sort of, how many people probably get home from the shift and grab caffeine and sort of, do you know what I mean?
You sort of need it by that point, don't you? You're desperate
and eating sort of like big, like I'm starving, and sort of eating big, like sort of like amounts of food, etc., and stuff like that, and then saying, right, I'm off to bed. And then can't sleep, and can't. Do you know what I mean? There's lots of these things, and I know from my circadian sort of rhythm from having ulcerative colitis, and what I should be doing, that whole 12-hour gap of sort of not eating to give it's more the small intestine than the large sort of like time to sort of like, and you learn these things, but we're not educating people, are we, in relation to that? And I think we need to be.
No, and I think understanding is often part of the challenge. Understanding our sleep and circadian rhythm biology, and understanding how the two interact, and this whole idea of, generally in sleep medicine and the things that drive us to sleep, we talk about the fact that over the course of a day, as soon as you wake up and until you go to sleep the next night, your sleep pressure is slowly building up throughout the day. So as soon as you wake up, your need to sleep is going up and up and up and up and up until you sleep and you reset it. And counteracting that is your circadian alerting signal. That is, when this pressure is building up, your circadian alerting signal is keeping you awake to stop that sleep pressure causing you to need to sleep at 2 p.m. in the afternoon. And then it's the circadian alerting signal drops down before you go to sleep, and the two kind of align really nicely, and you have a lovely restful night's sleep, which is probably a very small proportion of the population who actually get that working perfectly. But then during your night shift, just knowing that is going to go completely to pot, because the reason why you can't sleep in the middle of the day is, even though you've not slept for however long, up to 24 hours, your circadian alerting signal is absolutely at its highest at 2 o'clock in the afternoon. So you're always going to wake up, and almost being accepting of that, understanding why it's happening, and sort of being able to implement some attempts at solutions to minimize the damage of it are really important. I definitely found very, very useful on all the nights that I've done since I'm currently out of my training, as we're doing everything we're doing with Theta Sleep. So that has been one thing that certainly no night shifts has been a real delight, and it makes a massive difference. The reality is, we know it's absolutely awful for you. We know it's an accepted carcinogen by the WHO, but we don't really know what to do about it. And talking of things that get you miffed or get you wound up about it, I think the lack of kind of research into how to improve the sleep of shift workers, and as I was mentioning at the beginning, the early trials are looking at melatonin to help shift work that then hasn't seemed to go anywhere. Like, it's just so frustrating that is not a focus in the NHS, that is, whatever it is, I can't remember what the stat of how, if it's one of the top 5 biggest employers on the planet or something like that, of like the amount that you could do to improve that if you put a bit of money and understanding into it should absolutely be an area, particularly around shift work, because of all of the impact it can have on people. And as you say, some people are better at it. If people are good on nights, great. They should be the people who are working nights, and if you really struggle around it, there should be some kind of things in place, mechanisms in place to try and combat that. I always really struggled. I'm a massive early bird. Like, I'm super, super early. Right. So really struggled with nights.
Yeah.
Fortunately, as an anaesthetist, it's either sort of has really hit the fan, or and you kind of, that will keep you awake and you will be switched on and running on adrenaline, or if there is any downtime, you can actually sleep. So you can't complain too much, because you do often get a bit of rest if it's a quiet night, and that was always made life a bit easier. But yeah, I think optimizing shifts to suit different people feels reasonably low hanging, and it's just because sleep is not kind of high enough on the agenda. I don't think that it's necessarily spoken about at kind of a directorate level.
And I think it's a tough nut to crack, because it's very contentious, the whole shift work. I know from, you know, being a ward manager of an orthopaedic ward, and being responsible for writing the schedule, the rota for sort of 40 odd people, and people knocking down your door saying, you've given me this and you've given me that, and I can't do and all this sort of stuff.
And it's impossible.
If you start introducing, look, I'm just saying about the practicalities. I'm not saying I disagree, because I'm absolutely with you that we need to sort of, like, you know, at least talk about it and discuss it in relation to that, and see what the options are.
Experiment with it, because you said the practicalities are impossible.
Totally, because there are, like you said, you know, there's people like myself, I'd be like that, stick me on permanent nights in relation to that, and it suits, like you say, it suits certain people, but then there's others that I remember some of my staff would like, please don't put me on nights, you know, and I would try and accommodate if you don't want to do them. I'm not gonna put you on nights in relation to that. So, Tom, we're coming to the end of the episode. It's been absolutely fantastic talking to you. But before we do finish, if you've watched any of our episodes, it's just to put you on the spot just one last time. And it's just, you know, if there's one takeaway for the audience in relation to some of the stuff that we've discussed, you know, what would that be from your perspective?
I would say, with my sort of sleep clinician hat on, would just be to consider and prioritize sleep in everything. You know, personally, how can you, what's going on with your own sleep? How can you, I don't like the words optimize and improve, because it sort of gets into this kind of biohacking space, which gets a bit kind of the blurred lines between science and making things up. But, you know, prioritize your own sleep, understand what works for you, and how you can use that to feel better in yourself and, you know, better in your work and everything you do. And from a clinical side, consider how much of an impact sleep disorders and sleep disruption has on every single aspect of your physical and mental health, and therefore every single aspect of patients' physical and mental health, be that in hospital, you know, recovering from surgery, recovering from pneumonia, recovering from whatever, or the links it has with every other condition. You said mental health before, you know, how much of that is driven by a kind of bidirectional insomnia relationship, comorbidities related to undiagnosed sleep apnea, those things. Kind of think about it, have it high in the mind when you're looking at patients or individuals in front of you, would be my kind of one hope or one request, key take home, I reckon.
Brilliant. That's absolutely fantastic. Tom, it's been an absolute pleasure talking to you and having a chat. I've really enjoyed it. Thank you ever so much for joining us on episode 31 of The Only Way is Ethics. And thank you to the audience for joining us. As you know, you can find us on Apple Podcasts, Spotify and YouTube. And just to let everybody know, if it's unfamiliar surroundings that we have, this is our first episode of The Only Way is Ethics at How House, which is a digital health hub and community. And this is the first of many. So any of our episodes now that will be face to face will be delivered from How House. Thank you ever so much to everyone. Thank you again, Tom.
Thank you very much.
And we look forward to our next episode.